Oh, good. Christina's already sharing her screen. Thank you so much. Welcome to Christina and Amy. This is your first mini summit with us here at the foundation. Um, to those of you who don't know her, both of them, they're lovely ladies from Boston who are amazing, and they want to study neurology and reproductive science. And I asked them after visiting with them if they would mind telling us more about it, because we get a lot of questions here at the foundation. So we're going to spend about an hour, maybe an hour and a half, just talking about it and what it means and why it's important to know both neurology and the reproductive side. And then we're going to open it up to questions. A lot of times we can't do these mini summits without our wonderful sponsor, UCB. So I always like to thank them in the beginning of our mini summits as well. And with that in mind, I'm going to introduce Christina Briscoe, who is a neurologist at Boston Children's. She loves neurology and epilepsy, but she is also interested in this reproductive side as well. So, Christina, if you'd like to take it away.
Hello, everyone. It's nice to meet you, whether it's here or in the future virtually. Um, I'm going to be talking about why we think multidisciplinary clinics are important for young women with epilepsy, including both the epilepsy perspective and the adolescent medicine perspective. Um, I'm going to make three arguments to you today about why we think that this is super important. The first argument is that counseling around reproductive health is often not given for young women with epilepsy or is inadequate. My second argument for you about why this is important is that seizures can be affected by hormonal changes in epilepsy. And my third argument is going to be that people are not problems, but we often treat them like a series of problems in medicine. This is my disclaimer about this talk that we are talking about all young women with epilepsy. And I want to recognize here that because this is the Sturge-Weber Foundation, that there's also incredibly important work being done around multidisciplinary care for patients who have Sturge-Weber syndrome. And that's not precisely what we're going to be talking about today, even though since most people who have Sturge-Weber syndrome will have epilepsy, we're talking about that aspect of things that actually isn't covered in this Delphi consensus that came out a couple of years ago. So while I think it is relevant to this group, I just want to acknowledge that there's also really important work that's being done in the Sturge-Weber space around multidisciplinary care. Okay, so I'm going to get started with my first argument to you, which is around counseling and how we do it, don't do it, and how well we do it when we do. So this is the American Academy of Neurology quality measure. So this is our national group that says what should neurologists be talking about with their patients who have epilepsy. And so this is a larger guideline, and they include three things specifically for women with epilepsy, beginning from the age of 12 or from when they first have their period, which we call menarche in medical terms. I want to point out that this guideline applies to people who have of all cognitive capacities, and so even the children who have severe intellectual disabilities and neurodevelopmental disorders are not excluded from these guidelines, which I think is very important. And per the American Academy of Neurology, we should, as neurologists, be talking to all patients who have reproductive potential about these three topics. One is about the potential anti-seizure medication's effect on how a fetus could develop in our pregnancy. The second is about folic acid supplementation. And the third is how anti-seizure medications interact with contraceptive medications. So why does this guideline exist? Why do we care about this? So they surveyed adult women with epilepsy, and only about 1 in 3 reported having ever received counseling about how epilepsy treatment might affect contraception, pregnancy, and folic acid supplementation. And we know that for our younger population, since I'm in pediatrics, that adolescents are at higher risk for adverse reproductive health outcomes, things like unplanned pregnancy and those sorts of things compared to their adult counterparts. And patients also have reported, and we'll go into this in more depth, that they do want pediatric neurologists and epileptologists input on reproductive health and want routine confidential education. And then why these three topics? So I'm not going to go into great depth with these because we can come back to them if people have questions. But I wanted to briefly go over why we should be talking about these three topics and for all women with epilepsy. So there's two ways in which anti-seizure medication can affect the fetus or baby of a woman with epilepsy who's pregnant. One is that they can cause or can be related to major congenital malformations. And these are things like cleft lip and palate, heart disease, and those sorts of things, or even spinal bifida. But these body malformations or major congenital malformations vary a lot depending on the drug. And so because the overall prevalence in the population of this is about 2 to 3%, we have some drugs like levetiracetam, which is also known as Keppra, and lamotrigine, which is also known as Lamictal, which don't have increased risk compared to the overall population. In contrast, we have other medications like topiramate, phenytoin, phenobarbital, and valproic acid, which is also known as Depakote, which have much higher risks than other of the child having a major congenital malformation if the mother is taking this medication during pregnancy. So I wanted to quickly distinguish this. This is not if they've taken it at any point in their lifetime, but this is rather if they're taking this medication and become pregnant on this medication. There's also a second way, in addition to these body malformations, these major congenital malformations, in which anti-seizure medication can affect the children of women with epilepsy. And that is on their neurodevelopment, meaning their IQ and presence of disorders like autism spectrum disorder. And so we know that while most children of women with epilepsy will be healthy and have normal intelligence and will not have neurodevelopmental problems, there are specific medications, and in particular Depakote, that is associated with a statistically significant difference in IQ based on high quality evidence. And again, this is not if someone has taken Depakote at any point in their lifetime, but if they're taking Depakote when they're pregnant. Similar to the major congenital malformations, there's varied risk depending on which medication someone is on. And so some medications do not have increased risk compared to the overall population. And those are medications like levetiracetam and lamotrigine, where the prevalence of autism spectrum disorder and intellectual disability or any neurodevelopmental disorder is about the same as the general population. So we don't think that these drugs likely have increased risk. However, there's other medications, and in particular, Depakote and topiramate are considered higher risk, where the risk of any neurodevelopmental disorder is significantly higher and maybe as many as 5 times higher. And so depending on which medication a person with epilepsy is taking, it's important that they know whether or not that they would be at an increased, their child would be at increased risk of having a major congenital malformation or a neurodevelopmental disorder based on which medication they're taking. And it's why individualized counseling is so important, because as you can see, some medications are much higher risk than others. The second thing that we should be talking with every year with every person with epilepsy about who has reproductive potential is on folic acid supplementation. And this is because it was out of that same high quality evidence study. It was a prospective. They followed women with epilepsy over many years. They found that independent of whatever drug people were taking, if they were taking folic acid when they became pregnant, the child's IQs were significantly higher. And so independent of higher low risk medications, so for example, lamotrigine is a low risk medication, and valproate is considered a higher risk medication, the child's IQ was higher at the age of 6 years old, and which is when IQ becomes stable if the mother was taking folic acid when they became pregnant and throughout their pregnancy. And so the official recommendation is that everyone who has epilepsy, who is on an anti-seizure medication, who has had a period or is having a period, or could have become pregnant should be taking folic acid supplementation. One, to get practice. We know that remembering to take daily pills is hard. And so we want people building those habits long, long, long before pregnancy is even something that's on the horizon. And second, because while none of us wants to think that it'll happen, unplanned pregnancies do happen, and we have seen unfortunate effects of that. So important to build habits early in people who could become pregnant. Dr. DeVasta is going to go more into detail with this, so don't worry about this extremely busy slide. But the third thing that we should be talking about with all patients is their individualized risk of how their anti-seizure medication may affect contraception and vice versa. So similar to those neurodevelopmental and major congenital malformation aspects, it's highly individualized based on which drug someone is taking. Some interact, some don't. And so this is my very simplified list of, does it affect how well contraceptives work? But as you can see, very individualized based on which medication someone is taking. And then there's the special case of lamotrigine, which is particularly hairy, and Dr. DeFosta is going to go into more detail about this, but just to say that we love lamotrigine because, as you guys saw, it's a relatively safe medication. If someone becomes pregnant on it, we think that their child is not at higher risk of adverse effects, and so we like it a lot in women with epilepsy. At the same time, we have to be very cognizant that there's a lot of drug-drug interactions that we just have to be aware of so we can choose the right medications to go with it. I hope I've convinced you that we should be talking about these things, both because of guidelines and because it's important. But I would say that as some of you may have experienced, we just don't do a very good job in talking about it in general. And some of that is, I think, the constraints of these 30-minute, 15-minute, 20-minute visits that just don't allow for a lot of counseling, particularly when there's a lot of other things going on. And second is just because a lot of people don't see other people doing it and therefore haven't learned how to do it well. Those are my personal hypotheses that are absolutely not evidence-driven, but those are my opinions, to be clear. What we do know from the literature is that only 60% or so of child neurologists report routinely discussing this, despite the guidelines. So this was after many years after all those guidelines came out. So a lot of people say, yeah, I don't talk about this routinely. And when we look at people's medical records, it's even worse. Probably only about 40% of people have a documented reproductive health care screening in their entire medical chart. And then pregnancy tragedies or sexual activity were documented in less than 5% of cases for these patients. So people are telling us that they're not doing it and they're not documenting it. So it's probably not happening a lot of the time. I'll say it gets more complicated, in my opinion, for adolescents. And this is some research that we've done with families who are affected by epilepsy, and that all of these guidelines and topics are very adult-centric, and they're very neurotypical patient-centric in that there's a lot of other things that may be important based on someone's developmental age and their cognitive status that aren't in those guidelines. And so when we asked young people with epilepsy what was important to them, as you can see, it varied by how old they were. And these were neurotypical patients who we asked how important these topics were for them. Younger adolescents said, pregnancy and epilepsy and parenthood with epilepsy, maybe not as important to me, whereas those were very important topics for young adults. And then these topics, things like hormonal changes, sex and epilepsy, contraception, were extremely important for the younger adolescents and the adults, but not fully encompassed by the guidelines. This is some research that we did with some of our colleagues. So probably those guidelines, even though we're already not doing those things, there's probably more that needs to be incorporated. And then getting beyond even actually doing it, what happens when people do it? And so we did a simulation study where we asked child neurologists to counsel on these topics. These were volunteers, child neurologists across the country who presumably were interested in this topic because they volunteered for the study. And we had them do 3 scenarios practicing their best effort of counseling young women with epilepsy about these topics. And even in this in this group, which presumably has a higher interest than some child neurologists might in this topic, and even knowing what the study was about, just a little over half actually addressed the 2 out of 3 topics. And only one person did not commit a factual error when they were counseling. Over 70% omitted key information that was really important. So, for example, like the teratogenicity of Depakote just wasn't mentioned. And so we know even when people do the counseling, we're probably not doing it particularly well. So that was my first argument, why we need these multidisciplinary clinics, and why it's so important to have the extra time to talk about these topics, so that adequate counseling can occur. My second argument for you is going to be a little bit short because I'm going to address a lot of it in the next talk. And the second argument is that seizures in young women with epilepsy can be affected by hormone changes. And I promise this is less long than the other the other section. We know that around 2 to 3 years before someone's first period, they start having hormonal changes in their body. And in some cases, this can either be the onset of epilepsy, or can worsen epilepsy in people who already have it. And so we think about probably between 10 and 20% of women with epilepsy have seizure onset during the year of their period. But if you count the fact that these hormonal changes are happening before and after, it's anywhere from 40 to 50% of women with epilepsy will have the onset of their epilepsy during the period where these hormonal changes are occurring. And we know for people who already have epilepsy, about 30% of their epilepsy will worsen when they start having their period. So certainly not everyone, but a significant percentage of people. There's also catamenial epilepsy, which we're going to come back to in a second talk, but I have to say that that's also an important reason here. So that's my second argument, is that there is interaction between hormones and seizures. And I certainly, as an epileptologist, while I have an interest, do not pretend to be an expert in hormones, and do not particularly understand them or how to prescribe them. And so therefore, these multidisciplinary clinics are important. My third argument is that people are not problems, but we often treat people like a series of problems in medicine. You guys have probably seen these charts where we list with arrows the different organ systems that can be affected by neurocutaneous syndromes like Sturge-Weber disease, where we point out how it might affect the eyes or the brain or the skin. And we're really considering things by organ system and people as these series of problem lists that I'm sure you guys have seen in the chart. And in medicine, because often people are seeing one doctor per problem that they have, a lot of people who have complex medical needs have fragmented care, fragmented communication between their specialists, can have challenges transitioning all of these specialists to adult providers, especially when there may be limited expertise in these disorders in some adult providers in some settings. The complexity of the neurologic management, which can be affected by all of these other organ systems, right? How someone is doing from a stress perspective or their mental health can certainly affect how their epilepsy is going. But they may be seeing 3 different specialists for those things who may or may not be able to talk with one another. And then we know that psychosocial and behavioral support is incredibly important, but often under-recognized, and that parents and families of children who with complex medical needs, adolescents and young adults with complex medical needs, often are doing a lot of work with care navigation and advocacy, trying to get the specialists to talk to each other. Specifically about transition, we're supposed to be talking starting at age 13 about transition with all youth and caregivers. And then by age 14, we should be in anyone who's expected to require guardianship, meaning someone who has significant intellectual disabilities or other medical complexity where they are not expected to be able to make their own medical decisions as an adult without some sort of support. Those conversations should start by age 14. We know that intellectual disability and epilepsy are common. About 1 in 4 people with epilepsy will have an intellectual disability. And a lot of people with intellectual disabilities, even more so than epilepsy, are not getting adequate counseling. We know that in people who have intellectual disability, sexual abuse is common, somewhere around 30 to 40%, depending on the setting. Often peers or relatives are the abusers. And we know that people want to be talking about these things. They want to be talking about sexual abuse prevention, menstrual hygiene. They want us to bring it up and not have to bring it up themselves. They're interested in these other topics that are considered for neurotypical individuals. But again, similar to our adolescent populations, it's probably necessary but not adequate, these current lists that we have. And similarly to our AAN guidelines, people report to us that they just aren't hearing about these topics. I'm going to skip through those because we're close to time. And so, ultimately, I think that what we're hoping to do with these multidisciplinary clinics, combining adolescent medicine and epilepsy expertise, which are occurring in several centers across the country. We have collaborators in Alberta, Canada, Louisville, Kentucky, and Pittsburgh, who have similar clinics that they've got set up within the last couple of years. We're really trying to reimagine what this could look like with a couple of very simple questions that I think drive what we're trying to get at, both in terms of counseling and putting patients and families at the center of their care. Considering what is most important for their quality of life, what problems are most important for them to address, and whose expertise and input is needed to be able to address those problems. And then how do we plan for the future? How do we think about transition, anticipate future challenges, and help best support people through adolescence into adulthood, no matter their cognitive status or disabilities. So these were my 3 arguments. I hope I have convinced you that the multidisciplinary clinics can be important solutions to these 3 issues of inadequate counseling, being able to address how seizures and hormonal changes in epilepsy can affect people, and also being able to deliver patient-centered care where the person and their family is at the center rather than a series of problem lists. And then I'm going to add a 4th thing here, which I won't go into in great detail, but I think is important to acknowledge as we wrap this up, and that there's just so much that we don't know about how to best support and treat young women with epilepsy. There's really a dearth of research and a dearth of investigation in this area, where often we're saying we don't know, we have no evidence. And it's why in combination with our collaborators, we're working to do research and try to better understand how we can support this population. This is our multidisciplinary clinic. Dr. DeVosta, you're going to be hearing from next. These are our social workers, Megan Kelly and Chris Ryan, that are critical for us. We hope to eventually expand and add more providers to our team. Particularly, I think that one gap that we're hoping to fill eventually is psychiatry. But this is our team. We've been doing this clinic for a year now, and I've personally learned a lot from the patients who have come through our clinic, and I'm very grateful for them. This is the group that I mentioned to you earlier, which is ECAM Epilepsy Consortium of Adolescents Through Menopause. We have a pediatrics group. This is the people who are in our pediatrics group who help us to think about guidelines and how to better deliver care, including this multidisciplinary model that we're building in several sites. This is Dr. Laura Kirkpatrick, who has a site with her adolescent medicine collaborator in Pittsburgh, and then Marie Clements. Where is she in this picture? I don't see her. She may have gotten cut off by my screen. And Dr. Marie Clements, who is doing a similar clinic in Louisville.